¿Aló? Hola, ¿qué tal? ¿Cómo están? Buenos días.
Good morning, everyone.
Good morning,
Hola,
everyone. ¿Qué tal? Bom dia.
we are just waiting the right time to start the presentation. But thank you all for being here. I'm really happy for this. Hi guys. We will start now. I'm sorry about the delay. Uh, so first, let me introduce myself. I'm Tamara. I'm ambassador from Brazil, from then Brazil. And good afternoon or good evening. I don't know where are you watching us. So it's a pleasure be to here today. I want to thank you a lot for being here. It's amazing. You are making this possible. In this first Pan American Day meeting, we have Argentina, Brazil, Colombia, and Peru as the speakers. But I was seeing the subscription list and I saw people from all of the world. And to be honest, it's great, it's big, it's magic. I'm really happy for all this. But before we start, I wanna talk with our Portuguese and Spanish audience just for thank for all this. So, hola. Espero que todos estén muy bien. Mi nombre es Tamara. I'm ambassador. Embajadora. Perdón. Desde Brasil. Y es un placer estar aquí hoy con ustedes. Quiero agradecer mucho por eso. En este primer encuentro panamericano de la DENDE, we have, I'm sorry, I changed the language. Nosotros tenemos Argentina, Brasil, Perú y Colombia como conferenciantes, pero estaba mirando la firma y vi que hay gente de todo el mundo. Sinceramente, estoy muy grata. Estoy un poquito nerviosa, como ustedes pueden ver, pero estoy muy contenta. Just to finish in Portuguese now. Oi, gente, eu tô muito feliz. Eu tô um pouquinho nervosa, como vocês viram, errei os idiomas e tudo, mas eu tô muito feliz por vocês estarem aqui, por vocês estarem tornando isso possível. E é isso. I'm sorry about all the language, but I just want to thank you really a lot for being here. So to start, we start with Peru. I want to call Rocio Casemiro y Uriel Tegli or Tegli. I don't know how pronunciation your name, but you are here. Can you hear me?
Hello, everyone. It's a pleasure to be here.
So let me just announce to you guys. Rocio is a third-year medical student at Universidad Peruana Caetano Herida, and she's a member of the DEN Peru. And Uriel, I think I am pronouncing your name right. I hope so.
Yes, it's Uriel.
Uriel, okay.
Thank you.
He's a four-year medical student at Universidad Andina del Cusco. He is a member of DEN Peru and currently president of the Peruvian Student Society of Neurosurgery and Neuroscience. They will talk about low-grade glioma. So You can start, guys. Good luck.
Thank you. So I will present my screen. Please let me know if it is, if you are seeing it.
Yeah.
Yes.
It's okay here.
Okay, so good afternoon. I'm Rocio. Today I'm going to talk about low-grade gliomas. Here is the agenda. Then the next one. Okay, so low-grade gliomas are defined as neuroepithelial tumors originated from glial cells of the central nervous system. They include grade 1 gliomas and grade 2 gliomas. In grade 1 gliomas, the cells look almost normal. They are low proliferative and can invade and can cure after total resection. In 2 grade gliomas, the cells look a bit abnormal. They also grow slowly, and this one can invade and can return after surgery as a higher grade glioma. And then I'm gonna start with the diffuse astrocytoma. Can you? Okay. Diffuse astrocytoma isocitrate the hydrogenase mutant. They represent 11 to 15 of all astrocytic brain tumors. They have an annual incidence of 11 to 15% of all brain tumors. The annual incidence is of 0.55 and 0.75 new cases per 100,000 of population. They also are slightly predominant in males in their mid-30s. The characteristic genetic profile of these gliomas are the mutation in this protein, the isocitrate dehydrogenase. Okay, and then in the next one, we're going to talk about the localization. They can grow in any region of the central nervous system, but they usually develop supratentorially in the frontal lobe, as we can see here in these MRIs. Then about the clinical manifestation, they are, can you pass the next one, please? They usually manifest as speech difficulties, change in motor sensation or vision, and with frontal lobe tumors, change in personality or behavior can be seen too. The next glioma I'm going to talk about is the oligodendroglioma, ADH mutant, 1p19 codylated. It has an annual incidence of 0.26 cases per 100,000 population. It represents 1.2% of all primary brain tumors and 5.9% of all gliomas. The age distribution is 35 to 44 years old, and they are predominant in males too. The genetic characterization of these gliomas is the concurrent mutation of IDH1 or IDH2, and this whole arm deletion of 1p and 19q. Next, about the localization, they arise usually in the white matter and cortex of the hemispheres, mostly in the frontal lobe, as we can see here too. And in these MRIs, a large right frontal tumor. Okay, about the clinical manifestations, they usually manifest in two-thirds of all the patients with seizures, also with headache and signs of increased intracranial pressure, with focal neurological deficits. And the last glioma I'm going to talk about is the ependymoma. It has an incidence of 6.8 of all the neuroepithelial tumors that decrease with the increase of the age of the patient. And it is also predominant in males. It can be located principally in the posterior fossa, followed by the supratentorial compartment and the spinal canal with less prevalence. Here we see an MRI with a large posterior tumor in the fourth ventricle. The clinical manifestations depends of the location of the tumor. For example, can you pass the next one, please? For example, for tumors in the posterior fossa, we see symptoms of hydrocephalus and increased intracranial pressure, such as headache, nausea, vomiting, dizziness, and sometimes ataxia. Next, I'm going to talk about the treatment. For the treatment, it is usually recommended to have a maximal safe resection. Can you pass the next one, please? For a maximal safe resection, we usually avoid zones that may cause neurological deficits. First, we have to run an evaluation with a CT scan or an MRI. Then we can proceed with a cortical stimulation mapping. That is a technique applied to avoid these lesions in the sensory-motor cortices. It is also a gold standard for mapping function and safe resection. It can be done in, can you pass the next one, please? It can be done in two ways: as a sleep mapping or an awake mapping. For low-grade gliomas, we recommend to apply an awake mapping. It is also the most reliable mapping because of the low influence of the anesthesia. Can you pass the next one, please? And here we can see an example of mapping of the motor cortex with the tumors signed with an X. Then we can finally talk about the post-surgery treatment. Oh, before that, I'm going to talk about the surgery. We mentioned it is a maximal safe resection. It is indicated usually for reliable tissue diagnosis and to improve the patient survival. And the next one, here we have a procedure of this maximal safe resection. And here we can see the opened dura with the tumor and the surroundings involved. And then we do a subpial resection of the tumor along with the Sylvan fissure opercula and attempt to remove the tumor en bloc, if possible. Finally, the tumor is removed from the cavity. Finally, as post-surgery treatment, it depends of the patient agreement and their diagnosis, but it is usually followed by chemotherapy with temozolomide and radiation therapy. Follow-up care includes also MRIs every 3 to 4 months. In ependinomas, especially, it is the same, but we have to proceed with intracranial radiation or intraspinal radiation according to the tumor that developed. And I think that's it. Then we will talk about the survival rate with Uriel.
Hello everyone, my name is Uriel Tagle. I'm going to tell you about the survival rate of the LGGs, of the low-grade gliomas. Well, in children, most low-grade gliomas are both highly treatable and highly curable, and is a uniformly fatal disease of young adults by the mean age of 41 years, and has a survival of approximately 7 years, but a better survival than patients with a high-grade glioma with Hook rating 3 or 4. And the LGGs eventually progress to a high-grade glioma and death. But there is a lack of general improvement in survival LGGs patients over the past 3 decades, and that points us to the need for an intensified focus on these tumors. Well, till 2015, there was an info that said to us that in adults, there is no comprehensive clinical prognostic or predictive classification for managing patients with LGGs, a classification that combines information in histology, tumor makers, and constitutive tumor genotype, and surgical treatment that have a good relative outcome, and this has led to confusion over. We bring to you a case of a recurrent oligodendroglioma with a 52-year-old woman that is evaluated in the outpatient neuro-oncology clinic for a routine follow-up. By the signs and symptoms, we have persistent fatigue, mild problems with short-term memory that had not changed over time, that is important, and no seizures. We have the past medical history, an evacuation of a traumatic subdural hematoma at the age of 34, and being diagnosed with an incomplete resection of an oligodendroglioma in the anterior left frontal lobe at the age of 39. By the family history of illness, there is a lot of tumors and cancer. By a dead mother of cancer, a live sister with a past removal of a node tumor in the neck, and a live daughter that had attention deficit hyperactivity disorder. By the current medication of the patient, we have a carbamazepine. For understanding this case, we will go through the past 12 years before and the present, the current presentation. So we have the past medical history. We have the background. The background said to us that 12 years earlier, the patient presented with a generalized tonic-clonic seizures 4 days after she had undergone a cesarean section. By the images, we can see an expansive, non-hazing lesion in the anterior left frontal lobe, as you can see here. This is an MRI obtained the time the patient initially presented with a postpartum seizure that show us a non-hazed, expansive, heterogeneous with T2-weighted hyperintensity lesion in the anterior left frontal lobe involving both white and gray matter. We can see too that there was no abnormal enhancement and no abnormal restricted diffusion associated with the lesion, as might be seen on the high-grade neoplasms. So by these findings, radiological findings are typical of a low-grade primary neoplasm of the CNS, but just a low-grade primary neoplasm. For the brain biopsy show us the classic find of a fried egg cells of the left. This biopsy was obtained from the left brain, the frontal lobe of the brain, revealed evidence of an infiltrating Hook grade 2 oligodendroglioma with low cellularity. This is important for us. Low cellularity with classic histological features that correlate closely with a correlation of chromosomes arms 1p and 19q. These are two biopsies of the same frontal lobe of the brain in different times. The figure A, as you can see, this is 12 years before. We are in the past. At the time of the initial presentation that show us the classical cells of oligodendroglioma, that are cells that have a round nuclei and perinuclear halos. By the pathological examination of the resection of the tumor, that show us, that confirm that she had an oligodendroglioma Hook grade 2 infiltrating the surrounding white matter. By postoperative, we have a presence of a residual tumor that extends into the right side of the genu of the corpus callosum, and we can see that that evidence at that time for support to use adjuvant therapy for that low-grade gliomas was lacking. So therefore, the patient received no further therapy and her condition was managed with active surveillance, monitored thereafter with serial MRIs. We can see the first post-op MRI that can show a residual T2-weighted hyperintensity lesion along the margin of the resection cavity that is most pronounced posteriorly in abuts the corpus callosum, which raised concerns about the residual neoplasm. In the management, this is for like we are through the first case to the first time presentation, and we are going through the history, the management from 14 till 52 years. So we have surveillance MRI scans were obtained after the initial resection and intervals of approximately 6 months for a period spanning nearly 12 years till our current presentation. We have seen now there is a gradual development that show us abnormal tissue infiltrating the anterior left frontal lobe that extends from the margins of tumor resection and involves both gray and white matter. In the 2 slides. This show us to expansive non-hazing tissue with T2-weighted hyperintensity abutting the posterior margin of the corpus callosum and the posterior margin of resection in the left frontal lobe, extending up continuously into the adjacent tissue, anterior inferior left frontal lobe, left insula, and anterior left temporal lobe. And we are now in the present, at the current presentation. After the patient underwent a second surgical resection, she had no neurological deficits, and she had a mixed of risk, high and low risk prognostic features. That's why she was older than 14 years of age, that she had a presurgical diameter of the tumor more than 6 centimeters, and she had no residual disease after the second resections. These finds are classic high-risk clinical features, and the most anti-molecular subtype of her tumor was associated with prolonged long-term survival, and there was obtained in these images was obtained immediately after the second resection. And this image, as you can see, this corresponds to an infiltrative neoplasm in the two of the images. We can see now the biopsy at the current presentation. This is a resection of specimen of the left frontal lobe obtained at the time of the current presentation that show us the higher tumor cellularity, as we can see in these slides, than the seen in the specimens obtained earlier. So we can see a more cellularity, higher cellularity than, as you can see here, some regions feature with nodules with even higher cellularity as in the upper left side of this image that I'm showing to you, which is correlated with an increased Ki67 proliferation index, for being more precisely of 9% higher than that typically associated with WHO grade 2 oligodendrogliomas. So, important points in the pathological findings was that there was not progression in the WHO grading in the following histological findings, and this is important. A DNA sequence analysis confirmed the presence of an ADH1R132H mutation of fluorescence in situ hybridization that revealed us a correlation of the chromosomal arms 1p and 19q. So, the adjuvant therapy for now is temozolomide 12 cycles without having a clinical significant adverse event. And we see the before treatment images and after chemo of temozolomide images. The follow-up images obtained after show a decreased abnormal tissue along the posterior margin of the resection cavity and left insula, and in the left insula and in the left anterior frontal lobe. As you can see, there is a good response of the chemo. So it's good for the patient. So these findings are consistent with, as I said as well, response to the chemo. By the final diagnosis, let's complete all the diagnosis of our patient with a 17 years of disease. This is an oligodendroglioma, WHO grade 2 out of 4, with an elevated Ki67 proliferation index, an ADH1R132H mutation, and correlation of 1p and 19q chromosomal arms. Conclusion by this case shows us that the management of low-grade gliomas is controversial because the risk of treatment must be weighted before initial treatment. So thank you, Oral. It was a pleasure to be here talking to you about low-grade gliomas. Thank you.
Thank you. Oh, okay, I turn on my camera now. Thank you. It was amazing. It was great. Congratulations. I love the presentation. Now, if you have any questions, you can put in this chat, and I will pass to the guys. Now we have another presentation, also from Peru. Will be Marta and Mariel. I hope I pronounced it right. They will talk about lymphoma. Marta is a 30-year medical student at Universidad Peruana Cayetano Heredia. She's an officer from Peru, and she's also general coordinator and founder of Tiempo y Cerebro, and she's volunteering association currently. Okay, I'm sorry. And also, she is currently director of at Sociedad Científica de Estudiantes de Medicina Cayetana Herida. And Mariel is a four-year medical student at Universidad Peruana Cayetana Herida, member of Faculty of Neurosurgical Society Peru, and boarding of coordinator of Sociedad Estudiantil de Ciencias Clínicas and Association de Estudiantes Cayetana Herida, currently president of Red Herida. Oh God, I don't say correctly this. Red Heridiana de Investigación. I hope it's this. Guys, are you ready?
Yeah, thank you.
You can start wherever you want.
You can see?
Yes, I can.
Great. Good afternoon. We are Mariela Anticona and Marta Vilca, and today's topic is primary central nervous system lymphoma, or PCNSL. These are the topics that we are going to discuss in this presentation. Firstly, what is the definition? Primary central nervous system lymphoma is an uncommon variant of extranodal non-Hodgkin lymphoma and can involve the brain, the leptomeninges, the spinal cord, and the eyes, without evidence of systemic disease, because when it is present, we have to differentiate it from a secondary tumor. Okay. Regarding the epidemiology, PCNSL represents around 4% of newly diagnosed primary central nervous system tumors. And in this graph, we can see how the incidence of PCNSL varied as the years went by. There was a peak incidence in the year 1996 and a decline in the trend afterwards. This trend has been attributed in large part to the changes in HIV incidence and management over the same time period. By contrast, incidence in adults over 65 years old has steadily risen, and men and women are equally affected. Finally, most cases of non-HIV related patients are diagnosed in patients between 45 and 65 years old. Okay. About the risk factor, the most notable risk factor for the development of PCNSL is the immunodeficiency, like HIV infection, iatrogenic immunosuppression, and congenital immune deficiency. And the presence of PCNSL in immune-competent individuals have been associated to a history of flu-like or gastrointestinal illness. And also, in addition, patients with autoimmune disease may be predisposed to develop either disease or therapy-related PCNSL. Okay. Clinical manifestations vary depending on the site of involvement and can overlap with each other. So first, we have primary cerebral lymphoma that in most cases represents as symptoms related to periventricular lesions in the brain. With 70% of symptoms being related to focal neurological deficits and 43% with neuropsychiatric symptoms. Okay. Now we have primary leptomeningeal lymphoma, and as we can see, it involves the leptomeninges and presents mostly as cranial neuropathies with 58% and spinal symptoms with 48%. Okay. Now we have primary dural lymphoma that involves the external layer of meninges and can involve the dura of the cerebral convexities, the skull base or spine, and may include headaches and cranial nerve deficits. And compared with parenchymal PCNSL, primary dural lymphoma tends to be more indolent and may be mistaken for meningioma preoperatively. Okay. Now we have primary intraocular lymphoma that refers to a PCNSL that is initially present in the eye with or without concurrent central nervous system involvement. present mostly as ocular symptoms with 62% and with behavioral or cognitive changes with 27%. And it should be differentiated from retroorbital lymphoma, which is frequently associated with systemic extranodal disease. Here we have two fundus photographs of the right eyes, and this shows a characteristical subretinal pigment epithelium yellow infiltrate, and this shows large clumps of vitreous cells. And finally, primary spinal lymphoma varies on location and extension and presents in 100% with progressive myelopathy and with 64% with systemic B symptoms and back pain. And also, we have to know that the pattern of weakness and sensory level, if it's present, will depend on the location and extension on the extent of the lesion. Okay. Now, the workup. First, imaging of the central nervous system with MRI with contrast or CT with contrast if MRI is contraindicated, but both fail to detect leptomeningeal or vitreal disease. Second, we have to do a CSF analysis unless contraindicated, and we can see malignant lymphoid cells in up to 40% of patients. Here we have 4 MRI sequences, in all we can describe the lymphoma as a solitary non-hemorrhagic mass situated in the deep white matter adjacent to the periventricular surface. And the borders are sharply circumscribed in the majority of lesions. Also, myelin edema is present in the majority of cases, and it is usually less profound than which accompanies the metastatic foci of carcinoma. And third, slim lab examination of both eyes and intraocular biopsy. We can see yellowish white infiltrates the subretinal pigment epithelium and or vitreous opacity. Okay. Now, finally, for the workup, the biopsy, and we have to know that the most common histopathological subtype of PCNSL is diffuse large B-cell lymphoma. So it will be positive for CD20, BCL2 and 6, and MUM1, and negative for CD138. So here we can see a CD20 marker, the BCL6 marker, and the MUM marker, MUM1 marker. Finally, the treatment, we have to know that the standard combination of chemotherapy regimens that are useful in the treatment of systemic lymphoma are ineffective or toxic in the treatment of PCNSL and should not be used. We have to know that the basic treatment consists in high-dose systemic methotrexate, and is based on the age, the renal function, and the performance status, and the response of the patient.
Okay, so now we are going to talk about the survival rate, which is the percentage of people in a study or treatment group still alive for a given period of time after diagnosis, in this case, after the diagnosis of lymphoma of central nervous system. First of all, we have the median survival with radiation alone, which is from 12 to 18 months. Then we have the median survival rate of the group treated with high-dose methotrexate, which was significantly longer than the group treated with intrathecal methotrexate. In this picture, we can see how the intrathecal methotrexate is put on. This survival rate was from 13.8 months with high-dose methotrexate versus 2.3 months with intrathecal methotrexate. Then we have a mean survival rate of 16.6 months for patients who are less than 55 years old, and for patients that are 55 years old and older, we have a mean survival rate of 13 months. And another type of survival rate is the 5-year survival rate, which in this case for this type of lymphoma is the 30%. Now I'm going to present the clinical case. The present case report describes a woman with central nervous system lymphoma without any immune dysfunction. So let's read it. A 52-year-old woman presented to the hospital with a 1-month history of weakness in the right limbs and mental decline. 1 month prior to admission, the patient suddenly developed weakness and numbness of her right limbs, followed by slow responses and speech. While walking, her right lower limb would rock. She also experienced dysphagia, coughing, irritability, and apathy. Next, okay. So we have as epidemiological history that the patient had carried her father's decaying body to another grave site 2 weeks before the onset of the symptoms. So you see she had contact with decomposing corpses. We have here the supplementary tests. First of all, the MRI, which shows multiple abnormal signals in the brain, suggesting the possibility of infectious lesions, most of all because the epidemiological history we talked about a little before this. Here we can see what seems to be a unilateral increased signal hypertense image in the internal capsule, caudate nucleus, and thalamus on the right hemisphere. And these arrows from the left hemisphere, we can also see here some hypertense shapes, which are really small. Okay, another laboratory results that we got from the patient was, first of all, the cerebrospinal analysis, which was normal. No abnormalities were detected also on the whole blood cell analysis, and all seemed to be normal. Next one. Okay, and the neurological exam showed us that the patient had an impaired orientation, memory, cognition. She had a slow pharyngeal reflex, and her muscle strength was lower in the right lower limb. Okay, I made a timeline of the things that happened to the patient. First of all, the provisional diagnosis was a viral infection when she was admitted to the hospital. Then on day 11, there was no significant change in the patient's condition. Between day 0 and day 11, she was treated with acyclovir and dexamethasone, and there was no change. Then on day 13, the patient's condition deteriorated, and she developed dizziness and disordered consciousness. She was transferred to another large hospital also for neurology treatment, and she underwent other tests, which also turned out to be negative. The muscle strength also weakened. And then now, before going to day 45, during this period of time between day 13 and day 45, doctors suggested that the patient undergo a cerebral biopsy, but the patient's family refused. So only nutritional support treatment was given because the antiviral treatment didn't work. Unfortunately, the patient's condition deteriorated a lot, and as we said before, so on day 45, the patient was transferred back to the first hospital, and another MRI was performed, and this suggested that the range of the intracranial lesions had increased. Let's take a better look. Can you? Okay, so we can see here the second MRI in most bigger picture, we can see that the lesions had increased and now appear to be bilateral. Now there's mass effect. You can see how the anterior horn of the lateral ventricle is smaller than before because it's all compressed there. And the bilateral lesions look way better now because before they were so smaller, especially on the left hemisphere. Could you go back to? Okay. So then the patient's condition continued to deteriorate because no new treatment was administered. Finally, on day 57, the patient underwent a stereotactic biopsy of the right temporal lobe by a neurosurgery. During the subsequent hospitalization, she deteriorated further and she died after 1 week. So could you skip some next? Okay, so now we have the biopsy results 1 week after the patient's death. The final diagnosis, as you can see there, is that she has a non-Hodgkin lymphoma, invasive primary diffuse large B-cell lymphoma of the central nervous system. And we can also see here the immunohistochemistry, which suggests us that the patient had CD20 positive, which is often is often characterized for diffuse large B-cell lymphoma. Also, and it's not mentioned here, but the tumor was a double expressor lymphoma that expressed BCL2, as if you remember what Marielle said before, this is also a marker for central nervous system lymphoma. So I don't have a slide of conclusion, but the conclusion is that because of the low incidence of central nervous system lymphoma in immunocompetent patients and the lack of specific clinical manifestations, and positive auxiliary examinations, the disease was easily missed and misdiagnosed also, as you can see here. A clear diagnosis requires a histopathological biopsy. Therefore, in patients with an unclear diagnosis of central nervous system diseases and a strong suspicion of primary central nervous system lymphoma, it's necessary to have a stereotactic biopsy to be performed as soon as possible to confirm the diagnosis. So that's all. Thank you.
Oh, I have a problem to turn on my microphone. I was talking and my mic is off. Just a minute, please, and we'll turn on my camera. I had a problem with my computer. So we had a problem. Okay. Can you go, Larissa?
Hello, everyone. My name is Larissa. I'm also from Dundee, Brazil. And I am very glad to be here today. And to our friends from Peru, you were great. Thank you for all these awesome lectures. It was very good. So thank you. And we had a little problem with the Peruvian doctor. So we are going to talk with her later. And now we are going to our next country, that is our friends from Argentina. So
to start the Argentina presentation, we will have Maria Milagros Ledesma. I really hope I am pronouncing it right. I am without a little practicing in Spanish. So Maria Milagros Ledesma will talk about astrocytoma. She's recently graduated from University of Buenos Aires, and she's also present officer at Dundee, Argentina. If you are ready, you
Yes,
can. Okay.
Can I share a screen?
Yeah, you can.
Okay. Okay, so well, my name is Milagros Ledesma. I studied at the University of Buenos Aires, and thank you for this opportunity. It's an honor for me to be sharing this meeting with all of you. Today I'll be talking of astrocytomas in general. First, I would like to give a short introduction to be more oriented. In the brain, we have different sectors where different tumors can develop. When we talk about intraaxial tumors, we refer to those that are located within the white matter of the brain and are often intertwined with healthy brain tissue. By contrast, extraaxial tumors are those that do not arise from the brain, but from adjacent tissues such as meninges or nerves and compress the brain. Here we got some examples of intraaxial tumors, which is the subject that concerns us today. Some of them are neuroepithelial tumors, astrocytomas, oligodendriomas, ependymomas, choroid plexus papillomas, neural cell tumors, embryonic cell tumors, and metastatic tumors. I am going to focus in this talk in astrocytomas. They are the most common primary brain tumor. They come from cells called astrocytes that are the most abundant cell group in the nervous system, and the signs and symptoms depend on the location of the tumor. This is very important because what defines the evolution of the tumor and of the patient is not only its histology, but also its location. If the injury is too deep, inaccessible, or is in an eloquent area, the prognosis will be given by the topography being really hard, its defined resection. Well, so here we got some examples of different places where astrocytomas can be placed. In the upper right corner, we have a posterior fossa astrocytoma. These kind of tumors are more frequent in the pediatric population, being brain tumors the most frequent solid tumor in this age group. In the lower left corner, we can see another astrocytoma, but this one supratentorial. Then we have this another example. We can see how astrocytomas can be placed in the spinal cord too. And we have also here this another insular astrocytoma. Now we're going to talk about the classification. We have two types of classification. The first is according to the spatial distribution. Type 1 are solid tumors that do not infiltrate the surrounding brain tissue. Complete surgical resection is possible, and in general, it has a favorable prognosis. Type 2 are solid tumors that infiltrate the surrounding brain tissue in eloquent areas. Complete surgical resection is not possible, and in generally, they must be complemented with radiotherapy or chemotherapy. Then type 3 are tumors without a solid mass. They diffuse, infiltrate healthy tissue, and coadjuvant treatments must be done to control the disease, which is not always possible. The other classification is according to histology, and it considers the presence of nuclear atypia, mitosis, endothelial proliferation, and necrosis. Grade 1 do not have any of these characteristics. Grade 2 have only one characteristics, and examples are fibrillar, diffuse, or protoplasmatic astrocytomas. Then grade 3 have two or of these characteristics. The example is anaplastic astrocytoma, and grade 4 have 3 or 4 of these characteristics. And the example is glioblastoma multiforme. Well, for the diagnosis, our first approach to the tumor will be the clinical presentation of the patient. According to his symptoms, we will have a first suspicion of its possible location. Some of the possible presentations will be headache, nausea, seizures, or signs of neurological focus, such as speech disability, muscular weakness, or cranial nerve dysfunction. In the astrocytoma that is located in the spinal cord, we will probably find paraparesis, quadriparesis, paresthesia, etc. Then we will continue the diagnosis with images like CT and MRI. CT provides precise data of the location and extension of the brain mass. An MRI must be done with and with no contrast, and it determines with greater detail the characteristics of the lesion. Low-grade astrocytomas enhance with contrast, while high-grade gliomas doesn't. However, the only way to know certainly the histology is with biopsy or surgery. Regarding treatment, it will be, of course, tumor resection, which can be complete, total, subtotal, or partial resection, always trying to preserve normal tissue as much as possible. Later, neoadjuvant treatments such as chemotherapy and radiotherapy will be evaluated in each case. So now my partner Pablo will continue the presentation talking about ependymomas. I don't know if he's there.
I'm here.
Hi.
Just a sec so I can share screen.
I'm just unknown to you, okay? Let me see, okay. The next presentation will be by Pablo, and he will talk about ependymoma. He's also recently graduated from University of Buenos Aires, and he's a member of Dengue Argentina. And you can go.
Thank you. Okay. Can we see the screen?
Yeah.
Great. Well, my name is Pablo Duran. Thank you very much for the opportunity to present this very short presentation. I will be talking about ependymomas. Ependymomas are tumors derived from ependymocytes, which are cells that cover the brain ventricles and the ependymal conduct in the spinal cord. As we know, the cerebrospinal fluid is originated in the choroid plexuses in lateral ventricles of the brain, and it goes from there into the third ventricle through Monro's foramen and through the aqueduct of Sylvius to the fourth ventricle. From then, it goes mostly to the subarachnoid space, and some of it goes to the ependymal conduct in the spinal cord. The ependymocytes are the cells that cover all this path except for the subarachnoid space. This tumor is not the most frequent, the most usual tumor in the central nervous systems. It represents around 5% of tumors in the central nervous system, and is more often found on children, except for the cervical location in the spinal cord, which is mostly diagnosed in adults. These tumors, the ependymomas, can be either supratentorial or infratentorial, but the most usual location is the floor of the fourth ventricle, which is infratentorial, and they usually metastasize through the neuroaxis, following the path of the cerebrospinal fluid in a way that it's called droplets. According to the location of the tumors, the clinical manifestations will vary. Supratentorial ependymomas can cause epileptic seizures and focal neurologic syndromes with symptoms such as muscle, sensitive, and cranial nerve deficiency and speech impediment, while infratentorial ependymomas can cause hydrocephaly because of the blockage of the plaques of the cerebrospinal fluid, and endocranial hypertensive syndrome with symptoms such as vomits, headaches, and photophobia. Either metastasis or primary tumors on spinal cord will produce different manifestations according to the location and the column of the spinal cord that is affected. They can cause motor, sensitive, muscle, sphincter dysfunction, paralysis, etc. in what are called the medullary syndromes. For the diagnosis of ependymomas, we will first need the clinical suspicion, the clinical assumption that we are going to find one, and so we will confirm it with images. We will ask for a craniospinal MRI, which is important in order to obtain a proper stage of the disease, keeping in mind that the way that these tumors usually metastasize through the neuroaxis. What we will see usually is an image close to this one, with a mass on the floor of the fourth ventricle associated with hydrocephaly that can be evidenced by the increase of the volume of the brain ventricles and the evanescence of the convolutions of the brain. If calcifications were present, they would also be an indicator that could approach the diagnosis to an ependymoma. As for the treatment, usually the first step will be the surgical resection of the tumor. Surgeons will try to remove as much of the tumor as possible without causing any neurological deficiency. And this step is usually followed by radiotherapy, keeping in mind that chemotherapy is not very effective in ependymomas in particular. Chemotherapy can prevent the tumor to grow, to expand partially and temporarily, but only on relapses, not on first-time diagnosed tumors. Finally, as the prognosis, the survival rate of ependymomas is about 41% to 5 years, but the prognosis worsens a little bit within the younger patients. That concludes the presentation about ependymomas. Thank you very much.
Thank you, Pablo. It was an amazing lecture. We learned a lot. And now I'm going to invite Dr. José Luis Ledesma. He's a neurosurgeon from the Pediatric Hospital Ricardo Gutierrez of Buenos Aires. And he's a member of the Neurosurgery Argentina Association and also neurosurgery professor in the University of Buenos Aires. Dr. Jose. Let's wait for him to be up. Hello, doctor. You are muted. Yeah. Hello. Welcome.
Okay. Hello. Pongo esto, Mili. Ahí está. Now, okay. I have to share my slide. Okay.
Okay, we can see the screen.
Okay, thank you for sharing this and the opportunity to share that knowledge and discussion about these passionate specialties, the tumors in neurosurgery. First of all, I'm grateful for Professor Salim. He's the father of the Dandy Society, and he's we have the opportunity to interchange our knowledge with the neurosurgeon or people interested in this kind of pathology, you know, all over the world. And one case is Buenos Aires, is our country, and you are invited to come here when the coronavirus allowed to tend to travel. It's these different parts of our country. And okay, we are surgeon, and the most important for our specialty, for us, our philosophy is the laboratory and to have a deep knowledge about the anatomy. The brain anatomy is very important for us, for surgeon, because our goal is to remove the tumor, and we prefer to leave the others thing about the other treatments for the oncologists, radiotherapeutics, but we have to know how to operate and have to remove the tumor of our patient. It's our mission, and the laboratory is the most important we have to do in our specialty. I show you a few cases of the astrocytomas. In this case, it's in the brainstem astrocytoma. We can see it's located between the mesencephalus and point, and we have this is very important anatomy. We can see the foreventricle with the two parts, and it's very, very important to know how we come to access to have to remove tumor for this part without damage these very, very eloquent areas. We have here the different part of the nucleus of the cranial nerves, and we have the free zone that we have to access to the deep part of the foreventricle. In this case, this tumor is located in the mesencephalus and point, and I show you how to remove this tumor. And we begin to separate the both cerebellum parts, and we have to access the foreventricle. We have to pass fast. And we can see the oblongate medulla, the foreventricle, and we can see the tumor up the medulla oblongata. This is the case in astrocytoma, the low-grade astrocytoma. And we are remove the tumor and obtain some biopsy. It is the deep part of the brainstem, or the upper part of the floor of the foreventricle. We have to respect the normal structure and avoid damage. And for this goal, we have to know deeply the anatomy. The foreventricle kind of a free zone we have to access, and the deep part. At the end of the surgery is the control post-operative. This is the patient. We have a little tumor remaining, and this is patient 4 years after surgery. The second case is the insular tumor. We can see the anatomy is very important with the gangliobasal tumors, and the insular tumor usually involve the artery, and we have to respect usually the deep part of the ganglion basal, and in this case we can remove this tumor, and this is the patient. This is a spinal cord tumor, astrocytoma, and I show you the surgery. We can see we remove the bone of the spinal, and this is the dura madre. And then about the microexpose after the open. We can see the spinal cord, and we have to avoid the bleeding to make the surgery without blood. And this, we can see the tumor after to medullotomy. And we can dissect the tumor and separate from the normal tissue with CUSA. We begin to remove the tumor. It's important to find both streams, the tumor, proximal and distal stream, and we have to do a big approach. And this tumor remain. And this is just the end of the procedure. And we close the arachnoid. And finally, this is the MRI post-operative, and we can see without tumor. It's exceptional that we have able to remove. We are able to remove the astrocytomas intramedular. More easily is to remove the ependymomas, but the astrocytoma is so hard. But in this case, we can see our little patient, he have a moderate paresy of the leg right.
¿Y la otra patita no la mueve?
And we have the 2 years later the surgery. This is the patient without the other treatments, only surgery. And finally, this is a third ventricle astrocytoma, and we get for the third ventricle about the transcaloso approach, and we can see, fortunately, we was able to remove totally this tumor. And for this kind of procedure is very, very important to know the anatomy. And this is the patient. And finally, when it is our job is improving the quality of life, not just delaying death. Thank you.
Thank you, Doctor. Was really, really good. I love all presentation. Thank you a lot. I was in the chat if has some questions. I don't think there is questions now, But if someone sent to us, I will send to Argentina represent for you answer when it's possible. Okay.
Thank you.
Thank you a lot. I love it.
Thank you for your time, Professor. It was a great lecture. Thank you a lot.
Now we will need an inter. I don't know the right
Break.
word.
A little break.
Yeah, break. A little break. We return in 30 minutes, and we also will put it on Instagram. So you come back in 30 minutes, okay?
Yes, and after this break, we are going to have finally our Brazilian friends to present their lectures. Okay, in 30 minutes, we are going to post everything on Instagram. Hello everyone, we are finally back. I hope you guys had a nice break. So we are going to have our Brazilian friends here. And the first one that I would like to present is Christian Douglas Santos. He's a third-year medical student at the Federal University of Sergipe. He's the monthly webinar chair officer at Walter Edende, Brazil. And he's also extension programs officer of the interest group Neurosurgery Now. He is going to present high-grade gliomas, and along with Letícia Guzzo Scremin. She's a fourth-year medical student at Universidade Positivo. She's also a member of the Brazilian chapter of DENDE. She's also a member of the interest group of neurosurgery at Mackenzie Evangelical Hospital, and she was also a mentor of neuroanatomy in 2019. So welcome, guys. The world is all yours, and we are very glad to have you here. So you can start.
Thank you very much, Larissa. I'm going to share my screen now, if it's okay. Can you see it, the presentation?
No yet.
Let me see. Just a second, sorry. You can't see my screen right now?
No. I don't know what is happening, but
I don't know if Christian wants to share, maybe.
Christian?
I'll try just a moment.
Can you see it now?
Oh,
Yeah,
yeah.
now you can.
Okay, now you can see.
Yeah.
Great. Okay. So first of all, I would like to thank very much the opportunity to be here. As we are in a neuro-oncology meeting, of course, we couldn't miss on talking about high-grade gliomas, since glioblastomas alone already account for 50% of all primary malignant neoplasia of the central nervous system. So this is a topic of huge importance, and I'm very glad to be here with you talking about it. So in this lecture, we will cover an overall definition of gliomas and its grading system so that you can be situated. It will also include the new WHO classification of high-grade gliomas. This new WHO classification is of extreme importance since it for the first time considered molecular markers to classify those tumors, and those molecular markers are very important for prognosis and also for the therapeutic approach. So it is, okay. We'll also cover the clinical presentation and the imaging exams, and Christian will approach with you the management and prognosis of these patients. So gliomas, they are the most common malignant primary brain tumors. They account for 80% of all malignant primary neoplasia of the central nervous system. And histologically, they share characteristics of normal glial cells. So we're talking about astrocytes, these star-shaped cells, usually connected to a blood vessel. They are responsible to control the molecular and ionic concentration of the extracellular medium so that we can have an optimal neuronal functioning. We also have the oligodendroglia, these more rounded shaped cells responsible for the myelin sheath, and the ependymal cells involved on the liquor production. So based on its histological behavior, we can have a well idea of prognosis. So it is very important to understand this grading system. Grade 1, we have low proliferative activity, low proliferative potential is where we find the pilocytic astrocytomas that will have a better prognosis. As for grade 2, we already find atypical cells. They are generally infiltrative in nature, but they do not have a mitotic activity very preeminent. This is where we find the diffuse astrocytomas and oligodendrogliomas, and these grade 1 and 2 are considered the low-grade gliomas, as it was discussed by Piru team. Now, grade 3, we already find mitotic activity and also nuclear anaplasia. Now, this is where we find the anaplastic astrocytoma, an infiltrative astrocytoma, and the anaplastic oligodendroglioma. As for grade 4, we already have neovascularity and also necrosis is where we find the fatal glioblastomas. So 3 and 4 are considered the high-grade glioma. Our challenge of today to discuss is high-grade gliomas. So glioblastomas, they account for 60 to 70% of these high-grade gliomas. And as I said before, for almost 50% of all malignant primary neoplasia of the central nervous system. So this highlights its huge importance when considering clinical and surgical approach. We also have the anaplastic astrocytomas that account for 10 to 50% of the high-grade gliomas, and the anaplastic oligodendrogliomas that account for 10%. The rest is compounded by ependymomas and anaplastic gangliomas, which is a neuroglial mixed tumor. Now, as I said before, the new WHO classification for the first time included molecular markers into the classification system. And this was of huge importance, since these molecular markers, they can predict prognosis and can define the therapeutic approach. Which are these markers? Is basically the IDH mutation, as you can see here, and the loss of the 1p19q chromosome. So this IDH mutation, it is usually associated with good prognosis. You can see it on basically the lower grade tumors. So you have it on diffuse astrocytomas, anaplastic astrocytomas, and secondary glioblastomas. Secondary glioblastomas, as you can see in this chart, are glioblastomas that came from lower grade tumors, so from lower grade astrocytomas. So yeah, and now the loss of the 1p19q is also associated with good prognosis, especially on oligodendrogliomas. So here we have a table of this World Health Organization classification system, where you can see here that the anaplastic astrocytoma is divided based on the presence of this IDH mutation into anaplastic astrocytoma IDH mutant and anaplastic astrocytoma IDH wild type. And of course, also the not otherwise specified if it doesn't carry any of these mutations. Now, the glioblastoma as well followed these classification schemes. So it is divided in the IDH wild type that represents the primary glioblastomas, which have that have a worse prognosis, and the glioblastomas IDH mutant, the secondary glioblastomas, with more of a better prognosis when compared to the primary glioblastomas. And of course, the not otherwise specified if it doesn't carry any of these mutations. As for the oligodendroglioma, it is classified based on a combination of the 1p19q codeletion with the IDH mutation. So it is divided in the IDH and 1p19q codeletion, and the oligodendroglioma not otherwise specified as well. And finally, talking about the ependymoma, it is based on this RE-LA fusion positive ependymoma. Now, what to expect from a clinical presentation? We, of course, will have the general symptoms. So we're talking about progressive headache associated with vomiting. This association is usually because of the state of hyperventilation during emesis. So, and the mechanisms of headache can be multiple. We're talking about the mass effect associated with edema. It can be because of the compression of a sensitive structure. It can be because of the triad of Cushing that includes hypertension that can originate this headache, among other mechanisms. Of course, the intracranial hypertension can also lead to low level of consciousness, and epileptic seizures the patient can evolve. The mechanisms of this are being discussed yet, but is believed to be due to the blood-brain barrier disruption. It's also thought about the pH imbalance and the presence of cytokines. And changes in behavior and personality can also be expressed by these patients. So forgetfulness, irritability can also be present. As for the focal neurological deficits, it of course varies according to the location of the tumor. So if it happens, for example, in the precentral gyrus, the patient will have progressive motor weakness. Now, faced with an expansible lesion, we then follow with imaging exams, such as MRI. Actually, the MRI with gadolinium contrast is the best exam for brain tumors diagnosis. This is because it has sequences such as T1, T2, and FLAIR that are great that can bring us a precise anatomical image of the tumor. We have sequences such as DWI that can evaluate the tumor edema. DWI together with the ADC map can also bring us some information about tumor cellularity and malignancy. If you have, for example, so if you have increased tumor cellularity, we know that it comes from mitosis, multiple division. Then you will have a hyper signal on DWI, and ADC map, as it measures the water flow in the interstice, we will have lower sign on the ADC map. So we will have a higher hyper signal on DWI and a hypo signal on ADC map. Then we can infer tumor cellularity, which is of course more common on higher grade tumors, as we have mitosis activity and microvascularization, neovascularization. Actually, talking about vascularization, the MRI also allows us a perfusion study. As we can see here, higher grade tumors, they tend to have the neovascularization. So here we can see a warm perfusion on this sequence. So it also allows us a vascular and hemodynamic analysis of the tumor. Another sequence that can help the diagnosis using MRI is the spectroscopy. As you can see here, the spectroscopy studies the metabolites, the tumor metabolites. We can see the choline. Cholines indicators cellular turnover. We can see here creatinine that is useful to compare with other metabolites. For example, choline creatinine ratio bigger than 2 indicates tumor activity. That can be, for example, can be useful for the differential diagnosis from a post-therapy lesion, alterations in the tissue. So you can use this comparison to see the differences. We can also have the NAA here that indicates us neuronal loss. We have the lactate that indicates us hypoxia. So yeah, that's it. And here we have a functional MRI, a photography. It's a beautiful image. It's usually used to help on the therapeutic approach, as we can see very clearly the tracts and its pathways. Now, Christian will discuss with you the treatment and management of patients. Thank you.
Hey guys, right, when we talk about management, high-grade gliomas are usually very hard to work on. We have mainly three options, which are surgery, chemotherapy, and radiation. It's the basics of any tumor. But when we talk about gliomas, surgery comes to an important role into taking out the mass effect, as we said before. Um, that can improve the clinical status, that can improve the quality of life, which is the most important thing. We have to take into account the quality of life of the patient. It's really important. Our aim when we do surgery is for gross total resection, which is a concept that we have. Um, as Leticia said, most tumors are infiltrative, they are diffuse. We can find every tumor cell. So we only resect what we can see in the image, in the MRI. Um, that's the goal, to resect all of it. That's why it's called gross total resection. And sometimes that's not possible. Sometimes it's really hard due to anatomical reasons, due to the clinical of the patient. Sometimes that patient won't survive full surgery. Sometimes it's too close to a difficult area. So that's the case when you do a biopsy. When you have a tumor like that, you have to have a pathological confirmation of the diagnosis, which is you take out a part of the tumor, you send it to analysis, so you have to know what type of tumor we're dealing with. That will direct us to the proper treatment. Um, the maximal resection we can make when feasible, the maximum we can extract from the tumor, that's the best thing. But as I said, that's not the only thing. Usually you do surgery and then you have chemotherapy, you have radiation. Usually you use all of them. Radiation is usually used in a hyperfractional way, which means you take out 60 rays, which is a measure of radiation. You take 60 of it, and then you divide over 4 6 weeks, which is around 2 grays per session. Uh, and usually you add it to chemotherapy agents. The most common, as our Peru friends said, it's temozolomide. It's the most common chemotherapy agent. You usually have the radiation session, the concurrent temozolomide, which means you use them at the same time, basically. It's over 6 weeks, and then you add a couple more sessions of chemotherapy, which means only the temozolomide that will help with the progression-free survival. That patient has a limited amount of time. Usually these tumors are very aggressive, so there are no time to waste. So the better you have, the more time you have with no progression of the tumor, that's the best thing for the patient. And when you have the standard scheme, which is surgery, hyperfractional radiation, concurrent chemo, and then adjuvant chemo, that can extend the lifetime of the patient. Usually, it doubles the lifetime span. So, a patient is supposed to have only 10 months of life. When you add it to combined scheme, you have 23 months. It's a lot to take on a patient. There's also another type of chemotherapy agent, which is the carbazine, the CCNU, and the vincristine, short for PCV. It's usually used on 1p92 coagulated gliomas. It's been tested and mostly oligodendrogliomas. It's really great for them. Somehow it works perfectly, but not for other type of gliomas. So astrocytomas and glioblastomas, they don't really work that well. Studies right now, they don't show anything like, is that superior to temozolomide? Is that better? We don't have the answer. We just know that it's better for 1p92 gliomas. Uh, this type of agent is a lot more toxic. So it's a lot more seductive to use the temozolomide. It's easier, it's less toxic for the patient. So it's the standard one, but it's good to know that we have other possibilities. Please, next one. Next slide, please. Thank you. When we talk about surgery, we have a couple of techniques so we can have a safe resection and we can extract most of the tumor. A really ancient way to do surgery on the brain is awake craniotomy. It's not a new concept, but it's been rescued in years ago. It's not a technique that you use for every patient, but most of them are really beneficial when you have a tumor close to an eloquent area, which means speech area, motor area, sensory area. When you find out that the tumor is too close to that and you are not sure that you can take everything out and the patient is well, alive, functioning, if you don't know that, it's a good way that you keep that patient awake. There are a few contraindications on it. Not every patient can have that, which means large tumors that have a really intense mass spec, which means a midline shift of more than 2 centimeters. Obese patients, patients with psychiatric history such as depression, anxiety, patient with chronic coughing, intraoperative seizures. The list is pretty long, but that means not every patient is fit for this type of technique. But you can always optimize the patient prior to the surgery. On the pre-op, you can try to fix the patient. So if the patient is too anxious to be on awake craniotomy, you can have him on antidepressants, anxiety medication, try to work on it. If the patient has a large tumor, you could make a stage debulking, which means the first surgery you take out most of it, so you can take out the mass effect. And on the next surgery, you can do some intraoperative brain mapping, so you can find where is the eloquent areas, where are the tumor cells, another technique which has an image on the next slide I will show you guys is the fluorescent guided surgery with the 5-aminolevulinolic acid. It's 5-ALA. It's a really cool thing. It's kind of a sci-fi thing. You get a certain substance, which is the 5-ALA. You take it to the patient orally. It's a pill. You get him orally, and 6, 8 hours before surgery, that will make the brain look kind of reddish, kind of pinkish on the violet light. But the tumor, it doesn't glow like that. It gets on a greenish light, so you can see where the tumor begins, where it stops, where it's brain, where it's tumor. It's really interesting. So we have uh, a more safe surgery. We can also have the intraoperative MRI. It's the best friend of every brain surgeon when it comes to gliomas. We do functional MRIs, we do tractographies, we do the diffuse tensor imaging, so we can find out the the extension of the tumor during the surgery on image exam. And also we can study how close it is to some fibers, such as the motor fibers. It's a really good thing to use so we know where we can touch, where we can resect. That goes along with neuronavigation, image guided surgery, they are pretty close to it. There's also the laser interstitial thermotherapy for LIT. It's an old technique, it's a really old technology. It was delivered in the 70s, the 80s. Basically, have the thermal ablation of the tumor, so we use heat to shrink the tumor. It's not very common. I just added because it's a possibility, but it's not a very common way to use it. So I just thought you guys maybe should know about it. But it's something to have in mind. We have to keep surgery safe. And on the next slide, we have a few pictures for you guys. This is the 5-ALA acting out. On A picture, we have normal brain, white light, just conventional surgery, right? We don't know where is the tumor. We have some cheating right there. We know that's motor on the right part. We know that there is a big hole in the middle, which was where the surgeon was digging, but we don't know if we took it out. We don't know where it goes. And that's when favela goes. On the next pic, you have a fluorescent part in the middle. No, it was the next, that slide, the previous one. Uh, right there in the middle. Yeah, thanks. Right there in the middle. It's all pinkish. It's all different from the surrounding brain. That's reminiscent of the tumor. You can't see it on regular lighting, but on violet lighting and the use of 5L, it's a lot easier to know where it is. Now you can change it. That was the tractography, as I said, that's an MRI exam. It's supposed to tell you where the tumor is compared to the corticospinal tract. So you see, it's really deep in the brain on APIC. Other images such as E and F are really deep, but as you see, that's a nice resource so you can plan ahead. You'll know where the tumor is, you know where to dig, you know if it's too close to something really important. So when we are dealing with these tumors, we have to make a lot of planning, a lot of strategies to keep up with the function of the patient, keep up with the quality of life. And on the next slide, um, we're going to talk about the prognosis of these patients. It's really important to have a discussion with them previously to the surgery and previously to anything you propose to him, because some things of the tumor, some things of the patient will tell you how long the patient will live, how hard the tumor will take a toll on him. The first thing to take into account is the patient age. So younger patients usually have a better outcome, but all I can tell you is there is not much studies on older patients. Usually most studies stop at 65-year-old patients, so we don't know anything from that point on. We don't know if older patients, 70, 80 years old patients will have better outcome, or what kind of treatment we're supposed to give it to him. So there are very few studies on it. Most of them use the standard approach, as I said, the surgery, the radiation compared to chemo, and the adjuvant chemo. Um, we don't know a lot about it, and that's also hard because most studies have very few patients. The amount of patients that studies take are usually really small, so it's hard to find a conclusive uh, therapy for it. Another thing to take into account is the extent of resection. It's proven that the, the more you take out of the tumor, the more you resect of it, the better for the patient. The survival status is really higher. You aim for the closer resection. Sometimes you can't do it, but the more you take it, the better. They have zoological features such as, if it's an astrocytoma, an oligodendroglioma. That kind of changes because the oligodendroglioma, it usually have a better prognosis. You can have a patient that was very well treated. You resect all of it, you took him to radiation, probably will have 14, 15 years of life, but an astrocytoma, you are not that safe. Sometimes they have 2, maybe 3 years of life. That if they don't evolve to a glioblastoma, which is the next lecture. Um, these kind of tumors are more aggressive. You have to know what you're dealing with, hence the biopsy on the surgery. So it's a more aggressive kind of tumor. Another thing to take into account is the performance status. Usually we have the Karnofsky score, the KPS. It's a nice scale. It goes from 0 to 100. 100 means the patient alive, well, it's no symptoms at all. He functions perfectly. The disease doesn't take anything from him. He can work, he can study, he can practice anything. And 0 means he's dead, so the tumor doesn't have anything to do anymore. So the in between from 10 to 19, it means that tumor is taking something from the patient. Maybe he have a headache. Maybe he's not going to work anymore due to the tumor. Um, one of the studies that we use for this presentation have a patient that was 70 on the KPS. That means the patient doesn't work anymore. He had uncontrollable seizures. No, no medication would control his seizures, so he couldn't get to work. That lowers his KPS. Uh, there is also maybe the patient is in bed most of the time. Maybe he can get out of bed. That lowers even more the KPS. And even worse, the the status on that KPS is the progression. I mean, if you have a patient that is in bed all the time, but he's been in bed for 6 months, that's not so bad. But a patient that was alive and well, and suddenly he can't work anymore, suddenly he just can't get out of bed, that's really, really bad. That's worse. That patient has a better chance of survival. And that takes us to the fifth point, which is the mental status changes. Patients who have this mental status changes, they have a worse prognosis, which means a patient that gets in a coma or something. And the last thing that Leticia already talked about is the molecular features. Uh, when you talk about it, we have the IDH mutation, the 1p90q deletion, but I want to add to you guys something else, which is the MGMT methylation status. MGMT is a gene that fixes cells. You have a damage to the cell, so you have to be fixed, right? That cell has to be restored. And if you have a mutation of that gene, that means the cell won't heal. And that's good. That's really good because when you add chemotherapy, you're essentially destroying tumor cells. If that tumor have a mutation on MGMT, that means that tumor cell can't heal, which means chemotherapy will work wonders to it. That's the best thing you can do for a patient. Uh, if it's a mutated kind of tumor, it's really easier to work on it. But wild type tumors, which means no genetic mutations on this kind of genes, it's harder to work on it because the treatment options are usually directed to work on mutated type of tumors. So mutated cells are usually better to target, but wild type are usually more aggressive. They are fast growing. They are really difficult to debug, to shrink. So that's something else that adds to the prognosis of these patients. So you take these 6 things on account and you can know if the patient will have a shorter span of life or maybe a little bit more. But the most important thing is when you state that a patient has, I don't know, 18 months of life, you can take an aggressive decision to the patient if that means he will spend less time with his family and friends. As I said, quality of life and functioning is really important when we treat patients. So if surgery and chemo will take out his functional status, if we do surgery and he has a worse quality of life, that's not good. He has only 18 months alive, and you're taking uh, those months, uh, which it's not always just 18 months. A part of it is a quality of life, but a part of it means the patient will be in bed. The patient will be really in worse shape. So you can have the patient on surgery if it means that you will take quality time from it. So always think about the prognosis of the patient, how long he will live and how long you can give to him time with his family and friends. That's it basically for our presentation. We have our references right here, a couple studies so we can look on. And we would like to thank you all for having us.
Thank you guys. I love it. It was amazing. Thank you, really. I'm just one for this presentation. Now we're going to the next one, also from Brazil, and will be presented by Caroline Marques, I'm sorry, and Lucas Nascimento. Caroline Marques I'm sorry, a four-year medical student at 9 de Julho University, is a member of Walter de Neurosurgical Student Club Brazil, and she's also Extension Program Officer of the interesting group Neurosurgery Now, and is a member of the International Student Historical Network Brazil. And Lucas Nascimento are medical student, a third-year medical student at Federal University of Alagoas, and I need to say is my college too, and I'm really happy for this. He's a member of Walter de Neurosurgical Student Club Brazil, and he's also a head research of Project Longitudinal and Quantitative Study of Empathy Levels in Medical Students at UFAL. Guys, you can go. You can start now.
Hi. So I'm going to share my screen. Can you guys see?
Yeah.
Yes.
Okay. Can you guys hear me?
Yes.
Okay. So hi guys. My name is Carol. I'm a med student here in Brazil. It's very nice to be talking to you guys today. A little bit about what we've been studying here in Brazil. We are going to talk about glioblastomas, introduce the topic, and if you guys have any questions, at the end, we'll be able to answer them. First of all, we would like to clarify what glioblastoma is, what we're talking about. Glioblastoma is a malignant brain tumor, which originates from the brain tissue cells called astrocytes. These cells have been described as units that have the main function of support within the brain tissue. They have other functions, but their main function is this. We place an image on the right. This is the astrocyte cells. They look like a star. This type of tumor is aggressive, and according to a study conducted by the Central Brain Tumor Registry of the United States, between 2012 and 2016, they appeared first as the most frequent malignant brain tumor. So they accounted for 14.6% of all brain and other central nervous system tumors, and 48% of primary malignant brain tumor cases. So they were the most common malignant brain tumor. This research also showed that this type of tumor is more frequent in older adults, rates higher in individuals between 75 and 84 years old, men, white people, when they were compared to black people, and non-Hispanic people. The histology of this tumor is described as a high-grade astrocytic tumor containing areas of microvascular proliferation and focal necrosis. We place an image on the right to show you guys a microscopic examination of a glioblastoma exhibiting necrosis, microvascular proliferation, and vascular thrombosis. One key histological feature of glioblastoma is the detection of cell populations of apparently different degrees of differentiation. This is very common in this tumor. So glioblastomas, they are divided in some classifications that facilitate the study. So there are the primary glioblastomas, which are tumors that occur without any evidence of a previous less aggressive tumor, and secondary glioblastoma. There are progressions of less malignant tumor. Immunohistochemical evaluation allowed us to determine that glioblastomas are astrocytic tumor, but since 1996, it has been discovered that primary and secondary tumors, they have different genetics. So the identification of IDH1 mutation was essential. It is a genetic marker of secondary glioblastomas. It appears in about 80% of these tumors. And allowed us to do more accurate differentiations of these two classifications. So they divide the glioblastomas in three classifications: IDH mutant, which would be the secondary glioblastomas. This subtype corresponds to the minority of glioblastomas, about 10% of the cases. Usually they occur in younger patients, and since it corresponds to secondary glioblastomas, they are preceded by less aggressive tumors. When they discover IDH as a genetic marker for this tumor subtype, they also determined that this mutation was common in diffuse astrocytoma and anaplastic astrocytomas. Which are the frequently described as precursor lesions prior to the development of a secondary glioblastoma. There is also the IDH wild type. This subtype corresponds to the majority of the cases, about 90% of them, and they represent the cases of primary glioblastomas. They occur in older patients, and there are also many other differences between these subtypes. The clinical history, secondary glioblastomas tend to have a longer clinical history. Primary glioblastomas tend to localize in the supratentorial region, while secondary glioblastomas tend to localize in the frontal region of the brain. And there's also a third classification, which is the non-otherwise specified tumors. These categories includes tumors which IDH cannot be completely evaluated by the immunohistochemical exam. The clinical presentation of the glioblastomas will depend on the tumor location and how it spreads within the brain. But the patient may present progressive neurological deficit, motor weakness, headaches, and it can be along with cognitive and motor deficits, seizures, and there's a relationship between seizures to longer survival in patients who have seizure as a symptom to this type of tumor, because this symptom is usually related to younger patients and is associated with earlier diagnosis. There's also personality and mood changes. This symptom is related to tumors located in the frontal region of the brain. Language disorders when the tumor is located in the left hemisphere of the brain. The patient may also present symptoms of increased intracranial pressure, such as nausea, vomiting, dizziness, fatigue, and a few patients may remain asymptomatic. Now it's Lucas.
Good evening. My name is Lucas, and now we'll talk about the radiographic features of glioblastomas. Glioblastomas are typically large tumors at diagnosis with a thick, irregular enhancing margins and a central necrotic core. They can also have an hemorrhagic component and be shrouded by a vasogenic edema, which means that the vasogenic edema is caused by the spread of tumoral cells. 20% of the cases occur with a tumoral spread that can be seen as an abnormal white matter tract that connects two different areas of the tumor, in which is called a multifocal disease. Cases without this connection are called a multicentric disease. Now I'll talk about some useful radiographic information that we should all take note about. About the morphology, we should take note about the tumoral size in 3 dimensions, the presence of necrosis, and the degree of central necrosis, as well the relationship to an involvement of eloquent areas, white matter tracts, and large vessels. And last but not least, about the tumoral extension. If the tumor extends across the midline, if it extends into the brainstem, or if the tumor promotes CFS dissemination. I'll talk now about the tomography. It's common to find in the CT high cellularity with irregular and hyperattenuating margins, as well as irregular and hypodense center representing the necrosis. The glioblastomas are common to have a marked mass effect and be surrounded by vasogenic edema. Hemorrhage is occasionally seen, however, calcification is uncommon in this type of tumors. I'll talk about the MRI now, and here you can see the 3 sequences of MRI, T1 on my left, T2 in the middle, and FLAIR on the far right. And I'll talk about the difference between those sequences. In T1, the tumor will be hypo to isotense within the white matter and have central heterogeneous signals like necrosis and intratumoral hemorrhage. In the case of a gadolinium enhanced T1, the enhancement is variable but almost always present, and is typically peripheral and irregular with some nodular components. Usually, the enhancement surrounds the necrosis of the tumor. And in T2 and FLAIR, the tumor will be hyperintense, will be surrounded by vasogenic edema, and have flow voids that are commonly seen in the MRI. In the case of PET, the PET will demonstrate the accumulation of FDG that will represent the increased glucose metabolism, and this metabolism is typically greater than or similar to the metabolism of the gray matter of the brain. I've also selected a few differential diagnoses that I think are important. In this case, the cerebral metastasis, because it may look identical to the glioblastoma, and both may appear multifocal. Multifocal being what I said earlier, that there's a white matter tract that is abnormal, connecting 2 different tumor areas. But the main difference between metastasis and the glioblastoma is that metastasis usually focus on the gray-white matter junction and spares the overlying cortex, when that doesn't occur in the glioblastoma. In the case of tumor-effective demyelination, it may appear similar to a glioblastoma. However, the open ring enhancement is common in the case of demyelination, and it doesn't occur in the case of glioblastoma. The open ring enhancement being that the border of the tumor is non-continuous. In the case of the glioblastoma, it's a continuous border. And the most striking thing is that demyelination is more common in younger patients, and the glioblastoma is more common in adult and elderly patients. Finally, the cerebral abscess. The abscess has a central restricted diffusion that's unique to it. However, in cases of patients with hemorrhagic glioblastoma, the diagnosis will be more difficult. But we can separate the two because of the dual ring sign that is almost always present in the case of the abscess and non-present in the glioblastoma. Now for the treatment. The treatment usually involves biopsy, tumor debulking with postoperative adjuvant radiotherapy and chemotherapy, like the group before us said. And newer therapies include the anti-angiogenesis and immunotherapy. The STUP protocol that involves both the radiotherapy, the chemotherapy, and the biopsy and tumor debulking is recommended for patients younger than 70 years old. However, in patients older than 70, the radiotherapy is used as a shorter course of action, with the usage of temozolomide being ideal, especially in patients with MGMT methylated tumor, which are the non-active tumors. Even though there are many avenues we can take with the treatment, glioblastomas usually have a poor prognosis, with a median survival shorter than 2 years. And I'll talk about some of the negative prognostic factors in the case of glioblastomas. Both of the negative prognostic factors include increased age, degree of necrosis, degree of enhancement, deep tumoral location like the thalamus, lower pre-diagnostic functional status, and the tumor being a MGMT non-methylated or active tumor. I would like to finish our discussion with a phrase from J.R.R. Tolkien, that all we have to decide is what to do with the time that are given to us, because both us as the surgeons and the students and the patients need to do what we can do best with the time that we have, because both us need to find the best way to use our time to treat our patients, and then have to use the time the best, enjoying with their families and friends, because as I said, the prognosis in glioblastomas is not always great, and we have to cherish the time we have with the people we love. Thank you.
You are mute, Clarissa.
Sorry, guys. As I was saying, thank you, Lucas. Thank you, Caroline. You guys were great. It was a very nice presentation. Thank you. We learned a lot. And our Brazilian doctor, he had an emergency at the surgery room, so he's not going to be here right now. So we go ahead and we will go to Colombia, our friends in Colombia. Are you guys there?
Okay.
Hi there, it's Scar from Colombia.
And
this is Daniela.
I'm going to start to share my screen, okay?
Okay, let me just present you guys. This presentation will be by Daniela Perez. She's an medical intern at CES University. She also presents of Dendis Colombia. and by Carl Alexander Tohis. He's a four-year medical student of University of Pamplona.
Yes.
He's after, yeah, Pamplona. I had a little bit difficult with my Spanish. He's also after member at the Colombia and member of the then tumor focus team, neurosurgical scientific focus team. You can go, guys. Thank you.
Okay. So, hi, it's Carl Torres from Colombia. I'm four-year medical student at the University of Pamplona, like or Conrad you said. So we're going to talk about intramedullary tumors. So to start, we have to an overview about the spinal cord tumors, which can occur within or adjacent to the spinal cord. They are considered to be interaxial in location and can be either primary or metastatic. Primary spinal cord tumors account for 2 to 4% of all primary central nervous system tumors, and 1/3 of which are located in the intramedullary compartment. So we have to know the anatomy of the spinal cord related to this spinal cord tumors. So they can be classified according to their anatomic location. So we have the first one, the type intradural intramedullary, is as you can see in the imaging, the part A. So they arise within the spinal cord itself. Most primary intramedullary tumors are either ependymomas or astrocytomas. Metastases are being recognized with increasing frequency, primarily because of improvements in imaging modalities. The second one are the intradural extramedullary, which are tumors arising within the dura, but outside the actual spinal cord, which are termed intradural extramedullary. And the most common tumors in this group are the meningiomas and nerve sheath tumors. And the last one is the extradural, which are tumors, they are usually metastatic and most often arise in the vertebral bodies, and metastatic lesions can cause spinal cord compression either by epidural growth that results in extrinsic spinal cord or cauda equina compression, or less frequently by intradural invasion. We have now the intramedullary tumors. So they are spinal cord tumors that comprise a rare subset of central nervous system tumors that can develop at any age and have distinct management strategies based on histopathology. So the majority of intramedullary primary spinal cord tumors are gliomas. So what are the gliomas? The term gliomas refers to a tumor between a histologic resemblance linked to normal glial cells. The major types of glial tumors are ependymomas, astrocytomas, and oligodendrogliomas. So those gliomas, as well as non-glial tumors such as hemangioblastomas, are most common, with difference based on age at presentation, location within the spinal cord, and imaging characteristics. So in pediatric patients, astrocytomas are the most common type of intramedullary spinal cord tumors, whereas ependymomas are more common in adults. Now, we're going to talk about okay, where does the ependymoma start? Okay, so we have the ependymal cells which line the ventricles and central canal of the spinal cord, as we know. So to talk about the ependymomas in the spinal cord, they are the most common, as I just said before, the most common intramedullary spinal cord tumors, which are seen in adults, and the second most common seen in children. These tumors most commonly present in the 4th and 5th decades of lives and have a mean symptomatic duration of 21 to 37 months before the diagnosis is done. So we have a classification done by the WHO, or World Health Organization. Grade 1 variants are the first one, which are referred to as subependymomas, which are exceedingly rare. The second type is grade 2, the grade 2 tumors, which are named to the classic ependymomas, and they show perivascular rosettes or pseudorosettes and encompass distinct histologic variants, including the cellular, the papillary, the clear cell, and the tanicytic. And the last one is the higher grade, or grade 3, or anaplastic variants, which are very rare. Typically, they are very invasive, less amenable to gross toral excision, and carry a worse prognosis. So compared with the general population, spinal ependymomas are most commonly observed in individuals with the inherited tumor predisposition syndrome neurofibromatosis type 2. So spinal ependymomas most commonly occur in the region cervicothoracic and span an average of 3 to 4 segments within the spinal cord. We have difference between ependymomas, cranial ependymomas, and spinal ependymomas. They have been shown to be molecularly distinct. And also, studies have identified various potential molecular targets in ependymomas, including the phosphatidylinositol 3 kinase, or PI3K, signaling pathway, and epidermal growth factor receptor, or AGFR. The few clinical trials have explored the efficacy of treatments involving these targets, and their efficacy remains unknown because it's missing a lot of studies. Now, we have the symptoms. The most prevalent symptom in general is the weakness of the limbs. However, the presence of symptoms varies according to the location of the lesion. So, presenting symptoms vary based on the region of the spinal cord involved, and associated radiographic findings such as peridumoral, syrinx, and reactive edema. The most common presenting complaints include sensory motor deficits, myelopathy, proprioceptive deficits, and localized neck or back pain. More aggressive tumors tend to become symptomatic in a shorter period of time. And this is bad to the patient because this will be a bad prognosis. So now we have that the MRI is the imaging of choice for this kind of tumor. As you can see in the imaging, in the A and the B part, there is a T2 sequence where we can see a hyperintense tumor. Point. Okay, we have in the sequences T2, we can see a hyperintense tumor heterogeneously enhanced with administration of gadolinium contrast. Although in rare case, this can't happen. In rare cases, can be non-enhancing, confounding differentiation from astrocytomas. However, ependymomas typically occupy a more central location within the spinal cord because they arise from the ependymal cells, as I just said before, and that line the central canal and cause symmetric expansion of the spinal cord. This is one of the main features of the ependymomas that we can see in the MRI. In the part C of this imaging, you can see a T1 sequence with a signal hypointense, and basically those are the main features of the ependymomas in the MRI. Now we have to know something important too. It's the fact of the presence of intratumoral or satellite cysts and syringohydromelia, which can be seen in up to 90% of tumors at the rostral and or caudal ends.
Okay, so now before we get into astrocytomas, we need to understand astrocytes. So they are the most common glial cell type in the CNS, and they provide physical support to neurons and regulate the chemical contents of the extracellular space by restricting the spread of neurotransmitter, removing excess neurotransmitter from the synaptic cleft, and control extracellular concentration of certain ions such as potassium. So they act as a potassium buffer, amongst other things. Next slide. In adults, astrocytomas account for 30 to 35% of intramedullary tumors, making them the second most common intramedullary tumor. In kids younger than 10 years old, astrocytomas represent 90% of spinal cord tumors and 60% in adolescents, making them the most common in children. Despite being one of the most common intramedullary tumors, spinal astrocytomas only account for 3 to 4% of all CNS astrocytomas. They have a slight preference for males, and they have been linked to neurofibromatosis type 1. Histologically speaking, they can be divided into pilocytic, which is WHO grade 1, fibrillary grade 2, anaplastic grade 3, and glioblastoma multiforme, which is grade 4. It is also important to note that 85% of astrocytomas are low grade, and then 15% are high grade. The average presenting age in adults is 29 years old, and the clinical features include localized back pain, progressive weakness, and unlike ependymomas, paresthesias are more common than dysesthesias. These are usually localized in the cervical and thoracic spine, and the average duration of symptoms before diagnosis is 3.5 years for low-grade and 6 months for malignant astrocytomas. Here we have an image depicting the different sequences of an MRI, showing a normal-looking cord on the left side, and then comparing it to one with an astrocytoma on the right. So first, on a non-contrast T1, astrocytomas will look hypointense, and in some cases isointense. And on T2, the tumor looks hyperintense. On a T1 with contrast, the lesion will show mild to moderate enhancement, and this is important because most CNS astrocytomas don't enhance with gadolinium, but spinal astrocytomas do enhance with gadolinium 70 to 80% of the times. So we have to be careful, since 20% of spinal astrocytomas are not going to enhance with contrast. Another thing to note is the peripheral location of the tumor. Astrocytomas have an affinity for white matter tracts, which are topographically peripheral in the spinal cord, and this is why asymmetric cord enlargement may be seen. Next slide. This is another MRI. The first image is a T1 with contrast, and we can see a patchy non-homogeneous enhancement of a poorly defined tumor, which is characteristic of astrocytomas. And the second image is a T2 where the tumor looks hyperintense. It is also important to note that astrocytomas involve several spine segments, usually more than 4, because of their expanding nature, and they are not commonly related to hemorrhages. If hemorrhages are seen, it is more likely an ependymoma. Next slide. For the management of intramedullary tumors, it is important to use the McCormick rating, which is a scale used to evaluate a patient's functional state as well as tumor resection success. The gold standard of treatment is total resection, but this is not always possible, right? So especially more irregular tumors such as astrocytomas, this is going to be a little bit harder to achieve. Adjuvant therapies such as chemo and radiotherapy are used in high-grade tumors or in selected low-grade ones. Next slide. This is an algorithm depicting the different management routes that can be taken. So in symptomatic patients, some recommend resection while others, in asymptomatic patients, some recommend resection while others recommend monitoring. So this is a controversial topic. In symptomatic patients older than 65 years with McCormick grades 4 or 5, or with imaging highly suggestive of a high-grade lesion, it is recommended that medical therapy with steroids and radio or chemo be pursued. Biopsy can be considered if the diagnosis is uncertain. Then there are young patients with a good functional state, and in this case, surgical management is recommended. And then according to histology, if it's low grade, total resection should be attempted. If it's high grade, biopsy only with adjuvant therapy. And if total resection wasn't achieved, then radiation could be used. Next slide. Now, when it comes to prognosis, ependymomas have great survival rates, as do low-grade astrocytomas. Ependymomas have a survival rate at 5 years of up to 96% and 10 years of up to 91%. Grade 1 and 2 astrocytomas have survival rates of 82 and 70% respectively, and these dropped to 28 and 14% for grades 3 and 4. These low survival rates are related to the low probability of gross total resection in these tumors. Next slide. And finally, here we have a table summarizing the different aspects and characteristics of astrocytomas versus ependymomas. Next slide. Thank you very much for your attention.
Thank you, guys. It was amazing. All the presentation this afternoon here in Brazil yet. It was great. Thank you. Now we will for the next presentation, also from Colombia. In a minute, okay. And it will be about brain metastasis with Santiago Vargas and Stefania Cote. Are you there, guys?
Yes, here we are. Good evening.
Okay, just present you for the group. Stefania is a 50-year medical student at Sabana University, an ambassador of Dent, Colombia. And Santiago is a medical internship at Antonio Nariño University. And I'm sorry, he's a younger research at Antonio Nariño University. You can go. We already see your presentation.
Okay, thanks everybody. Hello. So here we are. Thanks to everybody that is here, the fellow Dundee members, doctors, and students. My name is, as says, Santiago and Estefania, and we're going to talk about brain metastasis. So here is a part of the content that we talk about most of the overall of this topic, because it's a very extensive, a lot of different things and physiopathology. So we're going to do this overview. So first, we're going to start to the epidemiology. So we bring this chart that says how central nervous system metastasis affects. So much of them become on the parenchyma or in the layers of such as leptomeningeal metastasis. It's important to note that the metastasis to form primary tumors is the most common things of cancers that we can find. Most of them are from lung cancers, then followed by breast cancers and kidney and renal cells. Also know that this is one of the things that most of we as fellow students will be seeing in our routine. So we need to know some of the symptoms like nausea, difficult thinking, double vision, headaches, difficult speaking, and swallowing. After know this, we're going to talk about the pathophysiology. So it's important to go back to like the basic things about the different membranes that we can, or barriers that we can find in the central nervous system. So as you can see in this picture in the figure A, we can see the blood-brain barrier that is composed by astrocytes and pericytes. And it's important to know this because they have a low transition, or something can be said as a low transitosis rates and a high expression of efflux prompts. So in here, it's very important to note that here is where the the brain metastasis will occur. And when this become an alteration, we can see the different steps that I will say later that will help the metastasis. Also, we can see in the figure B, the blood CF barrier that is formed with choroidal plexus epithelial cells that are connection via tight junctions with choroidal plexus capillaries. And it's important here, most in brain metastasis, because when the role of the C3 of the innate immunity that express the primary cancer cells can disrupt this barrier and help all the colonization that the cell can happen. And the last one, we can see most of the other picture about the lymphic vessel that can happen. Sorry about that. And all the lymphatic system that will also help to the metastasis. Now, what we're going to see is how, like, overview of one of the theories that are explaining how brain metastasis occur, that is called the seed and the soil. The seed and the soil starts when the primary tumor with all these cells starts to go in an invasion into the stromal environment, and is going to colonize over the next tissue where it's found, and it will then create an intravasation into the vasculature and go in the circulating tumor cells. This will go by, for example, here in this graphic, by hematological way, and it will go to every organ, in this case, the brain. As it goes to the blood-brain, as I say, it will, because of the different immune factors that it has, it will help to extravasation, and most of them will become dead cells, but some of them will become dormancy, and these dormancy cells will become proliferation. So here is the seeding, and then we're going to the soil, where it will be stay in the parenchyma or in the membrane, so the leptomeninges, and we can see that it will start like micrometastasis, colonization, and then after all, metastasis. So it's important to know this because this is how will be the involvement, and this a group of metastatic cells will create something that is called the brain tumor barrier. This brain tumor barrier will be very important in the treatment because it will show how the treatment can go efficiency to that cells and can kill them or make an excellent approach. After this, we're going to see the frequent metastasis to the central nervous system. So here is an overview of the most frequent one. We start with lung cancers. Lung cancer is one of the primary cancers that will make metastasis, most of them in the 20 or 56% of the patients, and is most common in men. The type of lung cancer that is more common are the small cell lung cancers. It's a neuroendocrine tumor. It's strongly associated with cigarette smoking, and when we have this primary tumor, we can use different images to know or to search in the case of metastasis, such as the PET scan, chest CT, bone scan, and brain CT and MRI. And the good thing about this is because in the treatment is very radiosensitive, and the surgical resection considered for immediately life-threatening large diseases. After that, we have the breast cancer, that it will be more common in women, but most of them in young women, if they have the presentation of HER2. This is very important, as a new study shows that there are different types of breast cancers, because as you can see, caused by luminal A, luminal B, HER2 positive and triple negative, and it will show different type of manifestation. One of them will be local a local metastasis, only one, or can be multiple, and this will be a more frequent solid tumor to spread by parenchymal disease and leptomeningeal. After that, we have the melanoma, which is one of the more wide overall, from the 10 and 70% of patients with metastatic melanoma have a brain metastasis. The median survival is from 113 days, and the meds contribute to the death of 94% of the cases. It's important to know, like, all the story of the patients, but also in the images, it will have some like characteristical manifestations, such as the presentation of the involvement of the brain and the PR anecdote with hemorrhage of imaging of an hemorrhage. Also a C2 who is likely hyperdense to the brain enhancement, and in MRI in the T2WI surrounded by intense halo edema, and then casing in T1-1 lesion patients with a melanoma highly suggestive of a melanoma metastasis.
Okay, so now I'm going to talk about the diagnosis. Next, please. So usually the brain metastasis manifest with mass effect on the brain and brain compression, and it can often be the cause of the initial presenting symptoms in patients with previously undiagnosed advanced stage cancer. So approximately 50% of patients present mild headache, and they are more common in patients with multiple or posterior fossa metastases. Papilledema is associated with headaches in 15 to 25% of patients, and up to 40% of patients with brain metastases present with focal neurological deficits such as weakness, numbness, and seizures. They can also present with stroke-like onset of symptoms due to intratumoral hemorrhage, and they can manifest altered mental status or impaired cognition. This is frequent experience by patients with multiple metastases. And it's important to know that brain metastasis should be suspected in any patient with known systemic cancer in whom neurological findings develop. Next slide, please. So for the diagnosis, we can use advanced neuroimaging techniques to identify brain lesions. So we can use the MRI with or without intravenous gadolinium contrast. This is the method of choice for the assessment of all brain metastases, and in particular has a better sensitivity over contrast enhanced CT for lesions in the posterior fossa. So the common radiographic characteristics that we can encounter in these patients are ring enhancement with prominent peritumoral edema, profound white matter edema, and spherical well-encapsulated shaped lesions, and the presence of multiple lesions in some patients. In the next slide, I will show a image of that. We can also use diffusion weighted MRI, which is helpful in the evaluation of ring-enhancing cerebral lesions. And it is also helpful for differentiating brain metastases from high-grade gliomas. And another image that we can use is the perfusion MRI, which is able to detect lower cerebral blood volumes in peritumoral regions. The next slide, please. So in here we have an image of a patient with multiple features of brain metastases. So in the first image, we have an MRI with multiple contrast enhancing mass lesions in both hemispheres, which are fairly encapsulated, and they are shown with the white arrows. In the image B, we can evidence on an MRI a significant surrounding of vasogenic edema, shown with the yellow arrows, and we can also see the associated mass effect of the lesion. In the image C, we have a T2 MRI with heterogeneous characteristics, including microsize. Then in the image D, we have the contrast enhanced MRI perfusion imaging that indicates the high perfusion, where the green color is. And in the areas of the blue and black color indicates the baseline brain perfusion. So where the green color is where the tumor is located. We have a diffusion weighted MRI showing minimal diffusion restriction compared with the, if we compare it with the differential diagnosis of infection and inflammatory processes, what we see in this image is different because inflammatory processes generally present with hyperintense signal. And in the last image, we can see a non-contrast CT showing hyperattenuating mass lesions as hyperintensities shown with the red arrows. And with the asterisk, there is a vasogenic edema shown. Next, please. So the histopathology is the gold standard for the diagnosis of brain metastases. This should be pursued in patients in whom the primary tumor cannot be identified and should be considered in patients with a long-term, well-controlled systemic cancer or active systemic cancer and cerebral lesions with a typical radiographic characteristics. And in patients with an unknown primary tumor, determining the lineage of the metastasis is important for deciding the therapies of both the metastasis and the primary tumor, and also in patients that non-surgical treatment is being contemplated, so we can know what type of tumor we have in this patient. Next slide, please. So Next, please. The immunohistochemical markers, there are some markers that we can use to detect unknown primary tumor. We in the practice they don't use these markers all the time, but in patients that they detect a lesion in the MRI or in the CT with an unknown primary tumor, these markers can help us know where's the primary tumor located. Next, please. So the differential diagnosis of brain metastases can be primary brain tumors like malignant gliomas or lymphomas, or non-neoplastic conditions like abscesses, infections, demyelinating disease, and vascular lesions. Next.
Something very important when we are dealing with cancer patients is the prognosis, because it's a very alarming diagnosis. So here we're going to expose the different tables and scores that we find that will help us know the prognosis of our patients. So usually there was used the Karpnowski score, which shows how will be the reaction to the chemotherapy. So it will be a score from 0 to 100. But after the years, they are creating different scores, such as the Radiation Therapy Oncology Group database, who makes this classification in 3, in which they group all the Karpnowski over 70 score. So it will be moderator or mild, age below 65 years, controlled primary tumor and not extraordinary cranial disease. And in the second group, we can find Karpnowski's over 70 with an age higher than 65 years old, and in control systemic defects or metastasis to the brain site, and who have a lower survival median from 70.1, that was the class 1, to 4.2 months in the class in the second class. And in Karpnowski, in the RPA class 3, we have a Karpnowski below 70, also it will be moderate and severe, and it will be in most of a terminal status from 2.3 mil survival months. So after this, we research, because we can use different scores now in our practice, and we found this, that is a score done by the Great Prognostic Assessment, which is new, that will take 6 items, in which will be the tumor type, the Karpnowski score, the extracranial metastasis, number of brain metastases, age, and if it's a breast cancer, it will show us the mean survival month. So it will be a calculator that we can use in our consultants and in our phones.
Okay, so for the screening, please, next. The screening varies on the basis of the presence or absence of a known primary tumor. So in patients with known primary tumors, we have to do a systemic staging, including all the assessments required for the specific tumor type to define the activity of the primary lesion and the existence of extracranial metastases. Also, there's a debate, ongoing debate, that talks about doing a screening for brain metastases in asymptomatic patients with an MRI. But in general, earlier detection and prompt treatment of small intracranial metastases less than 1 centimeter in size may prevent the development of neurological symptoms, reducing the need for resection and improving response to stereotactic radiosurgery. So in conclusion, the guidelines said that if the primary tumor is a high-risk tumor that can do metastasis to the brain, it's better to do the screening with an MRI. Then in patients with unknown or undetected primary tumors, these patients, the pursuit of these patients is unclear at this moment, but an abdominal CT to localize the primary tumor. Next. So for the treatment, the medical therapy for the brain metastases can be divided into 2 broad categories of symptomatic management and tumor targeting therapies. So first we have the initial treatment. This treatment is for the symptomatic patients. So we can use anticonvulsants like phenytoin or levetiracetam. These are often prescribed as an additional symptomatic agent in an attempt to decrease the seizure risk in patients with brain metastases, because as I said before, 15 to 20% of patients can present with seizures. Then we can use corticosteroids because many symptoms are due to edema, which is primarily vasogenic, and they respond to steroid within 24 to 48 hours. However, this improvement is not permanent, and as we know, prolonged steroid administration may produce a lot of side effects. So they recommend the use of dexamethasone 10 to 20 milligrams IV, followed by 6 milligrams IV every 6 hours for 2 to 3 days. And once the symptoms are controlled, we can administer 2 to 4 milligrams as long as symptoms do not worsen. And for the side effects of the treatment, we can administer H2 antagonists like ranitidine. Next, please. So traditional systemic chemotherapeutic agents have a limited role in the management of brain metastases because of the blood-brain barrier, because it has highly specialized transmembrane efflux pumps that export these drugs from the brain. So we can use radiation therapy that in the table at the right, we can see a classification of the most radiosensitive tumors and the ones with high resistance. We need to know these characteristics to see if the treatment would have any effect on the tumor. We can also use prophylactic cranial irradiation after the resection. They recommend the prophylactic cranial irradiation in small cell lung carcinoma because it reduces the relapse in brain, but does not affect on the survival. They also propose the use of post-operative radiation therapy, usually recommended following the craniotomy for metastatic disease, especially with the small cell lung cancer, and the stereotactic radiosurgery is another option. Next, please. So now with the surgical management, some of the reasons for selecting the surgery in these patients are to get the tissue for diagnosis, to do cerebral decompression, and prolong the survival when paired with adjuvant radiotherapy and in select cases. So we can divide the election of the surgery into categories, in the solitary lesions and in the multiple lesions. So in the solitary lesions, the indications favoring surgical excisions are if the primary disease is quiescent, if the lesion is accessible, if the patient is symptomatic, or this mass is life-threatening, and if the primary tumor is known to be relatively radio-resistant, and if we don't have any diagnosis. Whereas for the multiple lesions, these patients have much worse survival than those with solitary lesions. So there are fewer situations where we can use surgery in the multiple metastases. So those indications are one particular and accessible lesion that is clearly symptomatic and life-threatening, and the surgery will be as a palliative treatment to control the symptoms. If there are multiple lesions that cannot be completely removed, or if there's no diagnosis, so we can do the biopsy. Next, please. So we have the stereotactic biopsy. This one is considered for lesions not appropriate for surgery, like deep lesions or multiple small lesions, in patients not candidates for surgical resection, patients that have poor medical condition or poor neurological condition, or that have an active systemic disease, or to ascertain a diagnosis when another diagnosis is possible, and especially if non-surgical treatment modalities are planned, we have to do the biopsy. Next, please. So in this algorithm, this is for multiple brain metastases, and the treatment depending on the classification of RPI. And depending if the tumor is accessible or not, we consider different types of treatment like surgery or whole brain radiation therapy or stereotactic radiosurgery. Next, please. And lastly, we have the outcomes. So, next. The median survival with maximal treatment is only 8 months. Therefore, management is mostly palliative. By the time that neurologic findings develop, median survival among untreated patients is approximately 1 month. When using steroids alone as an alone therapy, the survival doubles to 2 months. If the whole brain radiation therapy and the steroids are used, the survival increases 2 to 6 months. If So if whole brain radiation therapy and surgery are used, the recurrence of tumors was significantly less frequent and more delayed with the use of postoperative whole brain radiation therapy. However, the length of survival was unchanged with this tactic. And in using stereotactic radiosurgery, they compared it with surgery. The survival with just the stereotactic radiosurgery is 7.5 months, whereas the just using the surgery alone is 16 points. So that's the comparison they made. And in the table, we have the factors associated with better prognosis, like having a Karnofsky score more than 70, patients less than 60 years old, only metastasis to the brain, meaning that there are no systemic metastases, absent or controlled primary disease, more than 1 year since the diagnosis of the primary tumor, and fewer number of brain metastases, and if the patient is female. And that will be all our presentation. Next, please. Thank you all for listening and being here. I hope you understood.
Thank you, guys. It was a great honor for us to have you here. It was a great lecture. And now I would like to invite Dr. Edgar Ordóñez Rubiano. He's a neurosurgeon at Fundación Universitária de Ciências de la Salud. And also he's an international member of the American Association of Neurological Surgeons. So Dr. Edgar, thank you for being here with us today. It's an honor for us. So the word is yours.
Thank you very much for your introduction. Thank you for your invitation to this meeting. It's a pleasure for me and an honor as well. And thank you to the Dandy Club, Dr. Salim, that is also present here. Thank you very much for this invitation. So I will just do a very little presentation about topics, just focusing on some surgical cases, right? Because you already talked about these topics. I will just continue with the brain metastasis, just because you were talking just right away. So I have no disclosures for this presentation. So this is the first case. This is a patient with this a 60-year-old female with seizures and right hemiparesis, 4+, and with a Karnofsky Performance Scale score prior to surgery of 90. She presented also a uterine hemorrhage, and on her workup, she presented a uterine tumor without any diagnosis. At this point, we usually do a thoracic and abdominal CT scan just to verify that there are no other lesions. So she underwent an MRI scan. This is a post-contrast T1 imaging of the head, right? So you can see here pterogeneous enhancing lesion in the left frontal lobe and pre-lesional edema that is very remarkable, right? And you can see here the sagittal and coronal views. Otherwise, no any other metastases were found on the scans. So we decided to go for surgery because of her pre-op KPS, only one metastasis, right? And we didn't know what was the primary tumor here. So we use usually for these cases that are close to these areas, and you know, this is an intraaxial lesion and you can get lost somehow. So we usually use a neuronavigation system in our protocol for these lesions. So we use the tripping fixation and use general anesthesia for these lesions. This is the incision pre-op delineation, right, of the tumor. This is how we usually use the neuronavigation system here. And this is how we do the craniotomy, right? Sometimes you can do a very small incision. Obviously, if you are skilled and have experience for that, I usually prefer to have enough visualization of the lesion. And this is how we find the tumor. This is very important. That when you are thinking about metastasis, you have to see if there is huge edema around these lesions. There are usually multiple lesions, right, and are very rounded. So this is very important when you are looking at the imaging of these lesions. And this is how you can double check in the neuronavigation system, just to show you, right, that you have to be careful with all the normal tissue around, because in comparison with other lesions, interaction lesions like gliomas, right? You here you have a capsule. We can talk about it, that is very well circumscribed. So when we go in surgery, right, we, as you could see here, you are not sure where the tumor is, or at least with the neuronavigation and with the craniometric points, you can go for it and try to see, but otherwise you are blind to see where the tumor is. So here we're already removing the tumor, right? So we usually use the bipolar cautery and the suction and try to find any cleavage plane in order to try to take the tumor in a piecemeal fashion. You can do also volumetrics for these lesions, aiming to achieve a gross total resection. This is the immediate post-op CT scan demonstrating a gross total resection of the tumor. She presented a good functional post-op follow-up. She, unfortunately, after 2 years, after radiation therapy and chemotherapy that was adjuvant for the treatment of this patient, after 2 years, unfortunately, she deceased. But what I want to focus here is that the main goal, right, was to give her good survival, but with good functional outcomes as well. This is the second case. This is the last case I will show of brain metastasis. So this was a 62-year-old female with seizures and also hemiparesis, predominantly on the left upper limb with a KPS score of 100. So she was on a good functional scale, and she had a prior diagnosis of breast cancer with remission and no other evident metastasis in other organs. So this is the post-contrast T1 images. So you can see here, there's a lesion here that is enhancing. Again, I want to focus on this. Look at the edema. You already talked about the, what you have to see. You have to look for other organs. You have to see if there are any other lesions, and see the features, the imaging features of these lesions, because those are very important in order to differentiate the tumor from other type of lesions, right? So if you can see here, it's very very near to the primary motor cortex. And so I decided to do a brain mapping for this patient, right, in order to preserve those motor functions. And as you can see here, it's also intraaxial. So we have to be very careful where to enter to do the corticectomy here. So these are the pre-op scans using the DTI, the tractography, to see where the motor tracts are in relation to the tumor, and see if they are displaced or infiltrated, and where is the relationship, right, to avoid lesioning them and try to focus where I'm going to stimulate. So we use electrophysiological monitoring, right, to see how the motor functions are during the surgery. This is very important. There are many ways to do it. I use a sleep craniotomy protocol for motor lesions, not for language area tumors. So we do the usual fashion craniotomies with the boreholes here. I'm completing the craniotomy, and this is the dura afterwards. And here you can see how we try to remove, as I told you, I prefer to expose very well the cortex in order to do a very good stimulation. So here, as any surgeon would think, this would be the best place, right, to do the corticectomy, because it's not as well as the rest of the cortex. However, when we did the stimulation, here you can hear how we double check with the electrophysiologist that we are in a non-eloquent area, right? Or if we are in an eloquent area and we try to put these numbers just to see where those areas are to avoid any lesion during surgery. So we decided to go through here, and this is after resection of the tumor, achieving a gross total resection. So just to remark these take-home key points, right? That it's important, as you said, that it's that the most important thing is to take a good decision, right, before the incision. So you have to see if there is any prior antecedent of any cancer, right? And if there's any cancer, prior diagnosis of cancer, and the patient has any neurological symptom, you have obviously to think before any other thing that probably there is any metastasis, right? So I always say that you have to see the horses know any zebras, right? Thinking the most important thing that there's probably in this patient. So at least you have to do a CT scan, sorry here, a CT scan to see if there's any lesion in those patients. Always check the functional activity of these patients, how the KPS is, the etiology of the cancer, right? If it's radius sensitive or no, and the number of metastases, the size, if there's any special location, right? It's in the bone, it's intracranial, or if there are other lesions associated. So you have to decide always what to do in a case-by-case manner. So this was about the brain metastasis, and what I also want to show you is, sorry, I will try to share a couple of things. So the first is to tell you that when you're looking at spinal tumors, it's very important to see where it is, right? To double check very well the images, because the anatomy is so important to see what's the probably etiology of the lesion. So it's very different to go for a bony tumor, right, than intracanal tumor. So the spinal canal, you have different spaces that you have to be aware of, right? So you have here the dura, and so you have an extradural compartment here. There's an intradural compartment and the intramedular space, right? So this is very important because depending on this, you can think about different tumors. And this is an extra dural and intradural, but extramedullary tumor, right? So you probably would think in schwannoma, but if it's only intradural, right, but extramedullary, probably you will think in a meningioma. But intramedullary, you have to think in those two that you were talking about, right? The ependymomas that are the most frequent, and the astrocytomas. This is very important because it's different to go for a schwannoma or for a meningioma or for an intramedullary tumor. Obviously, if it's intramedullary, you have to be more careful of and aware of the complications because you are going inside the parenchyma. So this is the first thing I want to show. And the last thing I want to show you is a case of an cervical ependymoma. Sorry, it's in Spanish. I'm sorry for that. So are you looking at my screen?
Yes, we're looking.
Okay. All right. So this is C5, C8 ependymoma. So the patient presented with quadriparesis, right? And Hoffman and Trumner signs. So you have to think about myelopathy, right? Or any compromise of cervical spine, and a centromedullary syndrome. I won't focus on that. And we did an MRI scan here. You can see after contrast administration how this tumor is enhancing, right? And here you can differentiate here the spaces. So this is them. This is the spinal canal, right? So probably here is the dura. So it's intradural, it's intramedullary. Here there is a cyst that probably it can be confused also with syringomyelia, or a cyst that is part of the tumor. So you have to go also for it. Otherwise, if you don't evacuate it, probably the symptoms will remain on this patient. So you can double check here the anatomy, right? So it's intramedullary, it's enhancing, so it's most likely an ependymoma in these images. It's very heterogeneous, right? Also in the T2 images. Okay, so this is already opened. This is the dura, right? With some stitches to separate this and get a better visualization of a tumor as well. So here you can see how is exposed the dorsal part, right? And you have to go in at trying to avoid all the lesioning of these functions that are pretty near between them. So we usually use the posterior approach, right? Trying to go through the midline to avoid lesioning the sensitive tracts as well. And here we are opening already the pia, trying to expose the tumor here, right? So we have to be very careful. We try to avoid any coagulation because the tumor is, intraparenchymal, so you can transfer the heat to the normal tissue. And if there is any chance to get a good plane to separate here, you can see how we're separating here the tumor from the normal tissue. And if there's any chance to take the tumor in one piece, that would be very nice. However, if the tumor is so big as this one, we prefer to do a debulking, right, to avoid the manipulation of the normal tissue, and try to take big pieces of tumor if possible. And we can also use the ultrasonic aspirator for debulking, right? So it will help us to improve the manipulation of the tumor without manipulating the normal tissue here. So on the right side of your screen is the superior aspect, right, of the patient. So now we are going to take out the piece that is close to the cystic part of the tumor. Continue to aspirate the tumor, and the debulking here. If you did, we can open a little bit more the normal tissue, until you have a good resection of the tumor. So that's what I want to share with you. I don't know if it was good and clear. If you have any questions that you want to do after the good presentations of the team. Thank you.
Thank you, Dr. Edgar. It was very nice to see all these images, all these cases, and this video. It was really interesting. So thank you for your presence here. I would like to tell you guys that our attendance list is at the comment section on YouTube. So if you didn't sign, it's the time to do it. And now I pass the word to Tamara.
Hi guys, to finish our event, we would like to call Professor Sarli Abdurrauf, who is our global president, to talk a little bit with us. So, hi Professor, how are you?
Tamara, Larissa, the team, I would like to congratulate you on such a tremendous effort for the Pan American Congress. I'm really impressed by the quality of the presentations by the students. Really, really impressive work. So I want to congratulate you. I would like to say hello to Dr. Edgar for his really nice presentation to showcase the surgical aspect of the pathologies that you're showing. So I just wanted to say hello. I wanted to really congratulate the organizing teams from our various clubs in Latin and North America for putting this symposium together. So my congratulations, and I commend you for the excellent work. Thank you so much.
Thank you, Professor.
Thank you, Dr. Salim.
Thank you, Ed.
So I think that's it. Thank you all guys for being here today. We are really, really, really happy for all. And I hope you'll doing again the second, the third, the 40th Pan American Dental meeting. Okay, so good evening for everyone. See you next time. Bye guys.
Thank you all. See you next time.
Thank you, everyone. See you.